Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialyse et Transplantation, Marcus at Home welcomes Professor Paulus Kirchhof in Hamburg, Germany, and Professor Jeff Healey in Hamilton, Canada, to discuss whether or not to give anticoagulation in patients with device-detected atrial fibrillation, based upon the data from their NOAH-AFNET 6 and ARTESIA studies, which have been presented at the last meetings of the European Society of Cardiology and the American Heart Association, respectively, and which have both been published in the New England Journal of Medicine in the last months. Dear Professor Kirchhof, dear Professor Healey, it's an honor and pleasure for us to host the two principal investigators of these two seminal studies.
Thank you. Also, from my side, thank you very much for joining and agreeing on this discussion. As a short introduction, whoever might not know the colleagues, Professor Kirchhof is director of the Department of Cardiology in Hamburg, in Germany, and at the same time holds a professorship at Cardiovascular Research or Institute of Cardiovascular Sciences at the University of Birmingham. And he is a well-known expert in atrial fibrillation research and chairs the board of the AFNET. So that is a German-based atrial fibrillation network where he pursues his interests in AF science, but also works on cardiomyopathies and heart failure. And we are very happy that he joined us to present the NOAH-AF trial, which was presented at the ESC Congress in the past August. Professor Jeff Healey is Director of Arrhythmia Services and Professor of Medicine at the McMaster University in Hamilton, Ontario, in Canada, as already alluded to. And well, he gained probably most of his reputation more than 10 years ago with the ASSERT trial, which, as I found out, was in 2012 the number 38 most cited scientific publication in the whole year across all publications. So I found that very interesting. ASSERT already dealt with subclinical atrial fibrillation in devices and the relationship with strokes and the possibility of preventing these strokes. And I think we'll see more of that in ARTESIA now, which will be presented by Professor Healey. And once these presentations are finished, Professor Bauer from Innsbruck in Austria will try and put these studies into perspective. Professor Bauer was already guest at Marcus at Home earlier when he presented the eBrave study, also dealing with the finding of subclinical atrial fibrillation. So he's an expert of that as well. Again, thank you very much for joining, all three of you, and we're very happy and looking forward to your presentations.
Thank you very much for these kind introductions and for providing a platform to discuss the NOAH-AFNET 6 and ARTESIA trials. It's a distinct pleasure to tell you about the results of the NOAH-AFNET 6 trial. I will, throughout my talk, use the term device-detected atrial fibrillation, because we now know, we've analyzed this, that 97% of the episodes of the patients that were enrolled in NOAH were device-detected atrial fibrillation, short and rare, but otherwise looking like atrial fibrillation. And I don't know whether Jeff will do the same. And that's, but that's a bit of an emerging consensus, I think, to simplify terminology. So these are my disclosures. I think the main funders to point out that supported the NOAH-AFNET 6 trial are the German Ministry for Education and Research and Daiichi Sankyo Europe. Now, about 30% of patients with implanted devices have device-detected episodes of atrial fibrillation. It's a bit less when you discount those who have ECG-documented atrial fibrillation. And really, we didn't have any data, any evidence to base decisions on anticoagulation or no anticoagulation on before we saw the results of NOAH and ARTESIA. Why did we start NOAH? And I think similar things apply to the initiation of ARTESIA. We all know that oral anticoagulation prevents strokes in patients with ECG-documented atrial fibrillation. In the absence of ECG-documented atrial fibrillation in patients with embolic stroke of unknown source or patients with heart failure, anticoagulation does more harm than good. And on the other hand, atrial fibrillation is often first diagnosed after a stroke. And of course, we would all want to prevent those strokes by starting anticoagulation earlier. Now, even, well, not when we started, but most of the data actually arose when NOAH was ongoing. There is data that suggests that less time in atrial fibrillation conveys a lower stroke risk. It was already known that paroxysmal AF has a lower stroke risk without and with anticoagulation than chronic forms. And as we know from the results of AFNET 4, early rhythm control therapy reduces cardiovascular outcomes, including a lower stroke rate. And the same was found actually in the ATHENA trial more than a decade ago. Now, when you look at the AF burden in patients with device-detected atrial fibrillation, in patients with paroxysmal atrial fibrillation and with a device, it's around 10%. They spend about 10% of their time in AF. And this is an analysis from the LOOP study. I don't have the data from NOAH yet. We will generate them and publish them in due course. It's 100-fold less on average in patients with device-detected atrial fibrillation. And therefore, there is equipoise, or there was equipoise, and we'll talk about whether there still is in this program. So patients with at least a CHA2DS2-VASc score of 2, but you will see the enrollment results in a minute, and atrial high rate episodes, but without ECG documented atrial fibrillation, were randomized in NOAH study to placebo treatment or to anticoagulation. Placebo contained aspirin, 100 milligrams per day, in those with an indication for aspirin, and nothing in patients without an indication for aspirin. About 55% of the patients received aspirin. And anticoagulation contained the NOAC edoxaban in the dose approved for atrial fibrillation. Primary outcome was a composite of outcomes that are relevant for patients and can be prevented by anticoagulation: stroke, systemic embolism, or cardiovascular death. And the safety outcome was a typical safety outcome of anticoagulation trials, a composite of major bleeding or all-cause death. All patients had an ECG every 6 months and were switched to open-label anticoagulation when that ECG showed atrial fibrillation. It was a high-risk cohort when you look at the clinical characteristics. 77 years old, quite a few with heart failure, most with several episodes of device-detected atrial fibrillation. And as I said, about half of the patients had an indication for aspirin. The median CHA2DS2-VASc score was 4. More than a year ago, at the beginning of September 2022, the Data Safety Monitoring Board recommended to the steering committee, and then there was a unanimous decision to stop the NOAH-AFNET 6 trial for expected safety reasons and the trend towards futility. And then we conducted final visits until the end of 2022. This is the primary outcome, the time to first occurrence of stroke, systemic embolism, or cardiovascular death. And that occurred in 83 patients randomized to edoxaban and 101 patients randomized to placebo. This difference was not statistically significant. When you look at the components of the primary outcome, the thing that stands out is that the stroke rate is only half of what we expected, around 1% per year. And you see a small reduction numerically from 1.1 to 0.9. There were no surprises in the safety outcome. Anticoagulants increase major bleeding, approximately double it. The hazard rate was actually 2.1 when you calculate the point estimate. And that was statistically significant. And when you look at the numbers, again, there were more major bleedings, and that component was actually statistically significant. And there were also numerically more death in patients randomized to edoxaban, although that may be by chance. These findings were consistent across many sensitivity analyses. We have since also published a sub-study that I think is quite interesting. We enrolled around 260 patients with device-detected episodes of atrial fibrillation that were longer than 24 hours. Patients where some clinicians felt even before we started the trials that they needed anticoagulation anyway. Based on a similar sized sub-analysis of the ASSERT study. One thing that I find intellectually interesting is that the patient characteristics are identical in those patients. So it's not that the patients with longer episodes are older or have more comorbidities. It's the same. Now, small numbers, but still the same. And there was no interaction between the treatment and the episode duration. And when you look at the survival curves here, you can think there may be a little trend, but again, when you look at the numbers, the thing that stands out is the low stroke rate, 1% per year. And again, these results were consistent also when we used the maximum episode duration as a continuous parameter. And not unexpectedly, the bleeding did not interact with episode duration. We did find more atrial fibrillation in those with longer episodes. And when you look at the follow-up, you see that about 30% of the patients had switched to open label anticoagulation because of ECG documented atrial fibrillation after 2 years of follow-up. So that's, and this is taken from the same review article that we published before the results of NOAH were available. I think it is still unclear, we are confused on a higher level, whether anticoagulation does more good or more harm in patients with device-detected atrial fibrillation. Thank you.
So thank you, Professor Kirchhof. And without any further delay, we're looking forward to the data of the other blockbuster trial.
So thank you again for the invitation, and really look forward to discussing these two trials because I do find them quite complementary to each other. So here are my disclosures as well as the funding sources for ARTESIA, and you can see, we're going to stay up here for a while. But again, like Professor Kirchhof said, you know, we've netted around this term of device-detected atrial fibrillation. We had alternate terms before. This was the term subclinical atrial fibrillation that we used for ARTESIA to speak about short-lasting asymptomatic atrial fibrillation lasting minutes to hours that was picked up by long-term continuous monitoring. And as we know from both trials, right, this is an issue for patients with pacemakers and implantable defibrillators, but more and more now with implantable cardiac monitors and long-term wearable devices, you know, this is very much rapidly becoming an issue for broader atrial fibrillation screening as this technology gets out into the general population. We knew right from the start that we were going to see a lower risk of stroke, as this was only associated with a 2.5-fold increase in stroke risk compared to clinical atrial fibrillation, which is twice as high. You know, as we'll see here, the stroke rates were lower, and this is why we felt anticoagulation, the value was unknown, and why we had equipoise for a trial. So to highlight the design features of ARTESIA, you know, we did have an upper limit, so 6 minutes minimum, up to 24 hours of device-detected atrial fibrillation to enroll, which compares to NOAH, where, as you saw from Dr. Kirchhoff's slides, they had individuals with longer episodes. We had a slightly more stringent criteria in terms of the CHADS VAS score, so had to be further elevated or have a history of stroke. And in our intention to treat population, patients were randomized double-blind to one of the two therapies, either apixaban in the standard AFib dose or to aspirin, and that was merely reflective of clinical practice in North America at the time. Most of these patients were enrolled in North America, and that was a time when we had slight differences in approaches to atrial fibrillation between the continents. And then finally, the key difference is we followed patients for a primary outcome, which included only stroke and systemic embolism. So those outcomes most likely to respond to the anticoagulant. And of course, the trial follow-up was quite a bit longer at 3.5 years of mean follow-up for patients. And like in NOAH, you know, we had many patients randomized. About 1 in 4 stopped study medication over the course of the trial because in ARTESIA, patients developed subclinical atrial fibrillation lasting more than a day. They were taken off the study drug and put on open-label anticoagulants. And as you can see, this happened relatively early, after about 18 months when this occurred. We had a further 35% of patients off study drugs. So again, when we look at the results, you know, more than half the patients are off study drug, which is quite important when you interpret the intention to treat results that we're going to present. It's an older patient population. 22% of patients died, but very few patients were lost or withdrew from the trial. So again, this slide is very important when you think about the effects that we see here in the study. We present our efficacy analysis for stroke and embolism using intention to treat. Our bleeding analysis was performed using on treatment to have a more sensitive look at bleeding, and our comparative analyses use intention to treat. So again, patient population is older, late 70s, with the typical collection of cardiovascular and stroke risk factors. The median CHAD score was just below 4, and draw your attention to the fact that very few people had a history of stroke or TIA, only 9% of individuals, and this is lower than we see in real-world registries. Longest episode, median value, was about 1.5 hours, and again, this is a slight difference between the two trials that we're discussing here today. And again, to reflect North American practice, you can see about 65% of individuals were taking antiplatelet therapy when the trial was started. So the primary outcome, again, stroke rates were relatively low, but significantly reduced in this trial with apixaban compared to aspirin, with a 37% reduction, which was statistically significant. The components, ischemic stroke, hemorrhagic stroke, all went in the same direction. And again, drawing one's attention down here, the modified Rankin score, the 3 to 6 range are your moderate to severely disabling or fatal strokes. And here we saw a 50% reduction in such strokes. So the big impact here was on large disabling strokes with apixaban. The bleeding, here just highlighting the differences between the analysis sets. We saw an 80% increase in major bleeding with apixaban using the on-treatment analysis, but no excess of fatal bleeding or intracranial bleeding, which in fact tended to be numerically lower with apixaban-treated patients. And you can see here, using intention to treat, still a significant excess of major bleeding, albeit here only 36%. And we further broke down the course of bleeding, and you can see here that most bleeding did resolve with conservative measures or supportive care, with only 8 to 10% requiring immediate measures to avoid death, and a small proportion of individuals, only 9 individuals in total, with bleeding that led to death, again, numerically more in aspirin-treated individuals. So again, and we can debate this in the question period, because I think it is a good matter for debate. If you look at intention to treat, you see roughly the same numbers of strokes prevented as bleeds caused. So this is not a straightforward decision-making process. When you compare the outcomes, about 45% of strokes with aspirin were permanently disabling or fatal. These were reduced by half. And on the bleeding side, fewer than 15% of the major bleeds progressed to death or required immediate life-saving measures. And these were in excess with apixaban-treated patients. So those were our conclusions, that there was a clear, for the first time, evidence that apixaban would reduce the risk of stroke and embolism in this patient population. Stroke risks were low, but significantly lower. There was a price to pay in terms of major bleeding, but in the severe causes of major bleeding, we found no difference. And we think that this is now a matter for debate, and ultimately will come down to guidelines and absolute rates and patient preferences and all these things that we can bring up nicely now in the discussion. So thank you.
Thank you, Professor Healey, and thank you both for those two excellent presentations. So what can we conclude? What can we learn for daily clinical practice? And we are very proud that we have another expert in the field, as you already heard, Axel Bauer from Innsbruck. He will try to solve that out for us a little bit.
So thank you very much also for inviting me to this excellent presentations and discussions. And I would like now to give in the next few minutes some thoughts. And first of all, I think it's important to say that congratulations to both of you for conducting and realizing these very important trials in this field. It's a huge effort, there's no doubt about that. And just to summarize the trial characteristics, you see here the numbers. Of course, the NOAH-AFNET trial was stopped early and included 2,500 patients, while the ARTESIA trial included more than 4,000 patients. Both included patients at advanced age, and in both populations, the CHAD-VAS score was increased. So this is really a high-risk population for stroke in case of clinical AF. There was difference in the drug, edoxaban versus apixaban. We can discuss about this. And there's also an important difference in the control arm. In the NOAH-AFNET trial, there was a placebo control group, while in the ARTESIA trial, all patients were given aspirin as control. And there's also an important difference in the primary outcome, which may have affected the efficacy to some degree. Ischemic stroke or stroke, general stroke, but also cardiovascular death. This was not the case in ARTESIA, which just focused on stroke or systemic embolisms. And of course, according to the premature interruption of NOAH-AFNET, the follow-up period, and accordingly, the power was substantially lower in NOAH-AFNET. If you look at the results, efficacy as well as safety, and this slide does not distinguish between primary and secondary endpoints, just focuses on the outcomes. You see ARTESIA is positive in ischemic stroke prevention and prevention of stroke or systemic embolism. We see no statistically significant effect in NOAH-AFNET, most likely due to reduced power. And if you look at safety, we have a numerically and statistically significantly increased numbers of major bleedings. But as we learned from ARTESIA, and I think this is very important to understand, fatal bleedings and intracranial bleedings were not particularly increased. Numerically, quite the opposite was true, compared, however, according to aspirin. There was also a study-level meta-analysis conducted by both groups, and I hope that a patient-level analysis is coming. And to put all these numbers together, we saw a significant effect on prevention of ischemic stroke if we combine both trials, on all strokes and stroke and embolisms. However, we see no effect on cardiovascular deaths or deaths at all. And we see an increase in major bleedings, plus 62%, but no increase in fatal bleedings. So this is these are the data. So what are my takeaway messages? First of all, I think we can conclude that DOACs in subclinical AF detected by pacemakers and defibrillators prevents strokes at the price of increased risk of non-fatal bleedings. We have to recognize that stroke rates in subclinical AF are low, approximately 1.1 to 1.2% per year, much lower than in clinical AF. And inclusion of cardiovascular death as composite of the primary endpoint may have diluted the effect of DOAC treatment in NOAH-AFNET. And finally, major bleeding was substantially increased by DOACs, but as we learned from ARTESIA, the rate of highly significant bleedings, fatal or intracranial bleedings, was similar, however, to the comparator of aspirin. So what are the clinical consequences? I think it's the similar situation as in clinical AF. We need to define the balance between stroke prevention on the one hand side and bleeding on the other side. This means that shared decision-making is of utmost importance, involving the patient. Management of modified bleeding risk is important, particularly if you make the decision for anticoagulation. And one should closely monitor the progression of clinical AF, because this may shift the balance towards increased ischemic risk. There are, of course, a lot of open questions. And first of all, from my field of research is, can the results of NOAH-AFNET or ARTESIA be extrapolated to some degree to AF screening by wearables, by smartphones, by smartwatches? Are these different populations? Can we learn important facts from these trials for future planned trials in that field? And then finally, and there I'm waiting particularly for the analysis of ARTESIA or the meta-analysis, are the factors which interact with the treatment effect. We heard that in NOAH-AFNET, the longest episode was not a significant, had not a significant interaction with treatment. But what about percentage of AF and so forth? and are there factors which characterize patients at increased bleeding risk, maybe, which might be more appropriate candidates for anticoagulation. So these are some thoughts, and I'm looking forward to the discussion. Thank you very much.
Thank you, Professor Bauer. So some comments or some thoughts from your sides, maybe Professor Kirchhof, you would like to start?
Well, I think that I want to echo what Axel said. I think these really, that they are trials that provide evidence in an area where we didn't have evidence. I have a particular high respect for the ARTESIA Data Safety and Monitoring Board, who decided to continue the trial after we stopped ours. Now, that cannot have been an easy discussion or decision. I think they did the right thing. I also think we did the right thing. And one difference between the trials is that the number of events is higher. It's about, when you count the strokes, it's about 100 in ARTESIA, it's 50 in NOAH. So I think that is, it's something that is helping us now. And I'm sure it's something that wasn't easy in the autumn and winter of 2022.
Professor Healey, you would like to share some comments on that?
Well, I mean, I'm not sure it was so much a difficult decision in retrospect. You know, you look back at you can see what the safety board saw in retrospect, and they were seeing obviously a signal even back then that this was likely to show benefits. So I think it probably didn't worry them so much, but I think your point is valid. I mean, I think now that we have, you know, these are going to be the only data we're going to have on this topic. No one's going to repeat these studies at this point. So I think they are, you know, good that we have 150 plus stroke events upon which we can base some recommendations for sure. I think, you know, the trials are good. I think the meta-analysis shows nicely that the effects on stroke are likely consistent, that, you know, we have a matter of power between the two trials. But, you know, the NOAH-AFNET 6 also trended in favor of stroke reduction, again, with low stroke rates in the control arms. But that, you know, I think that is a good first step to kind of explain to the community what's going on here. That we're dealing with low stroke rates, but in terms of what clinical trials really do best, which is to compare one treatment against another, I think we're seeing, you know, a consistent treatment effect here with stroke prevention.
I have a question, if I may ask. Everybody wonders what is the reason for the maybe different findings. What about the cardiovascular death and the endpoint? Is that the major driver of the difference?
Well, we know now that, you know, fewer than 6% of all deaths in patients with atrial fibrillation due to stroke in, you know, contemporary data sets. So it's not surprising. Most of these deaths are heart failure, right? So maybe you move the needle on that with an AFib ablation trial, perhaps. But with an anticoagulation trial, we're unlikely to move very far. And, you know, even in the older anticoagulation trials in atrial fibrillation, one had to reduce stroke by about 50% to squeak out maybe a 10% reduction in cardiovascular death that was significant on those meta-analyses of the DOAC trials. So it doesn't surprise me that cardiovascular death doesn't change, just because this isn't a big driver, especially, you know, since we use new generation anticoagulants where people are not dying from intracranial bleeds that we saw back in the era of warfarin. So I'm not surprised that cardiovascular death doesn't move.
I think there is I think it's important to highlight now, obviously the headline, Twitter or X findings of the trials seem to not align, but really the trial findings are consistent. And I think it's as Axel nicely summarized them, the stroke rate is low. Both of the design papers talk about a stroke rate of around 2% per year, and it's closer to 1% per year without anticoagulation. When you talk about outcomes, one thing that I find thought-provoking, but it's just a side finding, is that now in NOAH, we had a broader definition of systemic embolism than in ARTESIA. So we included pulmonary emboli, we included myocardial infarction, assuming that there would be a potential effect of an anticoagulant of these outcomes. And when you look at the numbers, this may all be due to chance, but there is, when you compare the numbers, the biggest effect that we see between the two treatment arms is actually in that systemic embolism part of our composite outcome. Whether it is better to have a more precise outcome, and I think we would all agree that stroke is probably the outcome that is most likely to be prevented by an anticoagulant. or whether it is more helpful to have a composite of outcomes that include events that matter to patients and that are sort of in the range of being prevented. I think that's you can debate that nicely, and if the outcome of NOAH would have seen maybe an even higher reduction in those components of the outcome, we would look at the things differently now. I think there are good arguments both ways. One thing that is probably worth considering when we talk about outcomes is that that there was no effect on cardiovascular death, as you've heard, even though we saw the 10% reduction numerically that we thought when you put both trials together, it's actually almost bang on the line of identity. There is a bit of a signal about mortality. It's not significant, but the total number of deaths in the patients treated with aspirin or no anticoagulation is a little bit lower than the total number of deaths in patients treated with anticoagulants. I don't think that this is a direct effect of the anticoagulant, but I do also think we all know situations where a major bleed is not deadly, but leads to a cascade of things that then create further problems. And I think that is something that we will find out. And I, as Axel said, look really very much forward to the patient data meta-analysis, because I do think that we can tease out a lot more of those details once we are able to combine the data sets. Now, that will take some time, but I think
we probably disagree on this one, Paulus, because I think most of those deaths were non-cardiovascular deaths, right? I mean, the big difference in death between the two treatment arms is non-cardiovascular, and of course, bleeding-related death is a cardiovascular death. So I'm pretty sure, and plus we looked at the clinical course of bleeds in ARTESIA with great detail, and there was no excess. In fact, there were numerically fewer bleeds that led to death with apixaban compared to aspirin. So again, I think the most likely is play of chance there. And when you have a large group of older patients, like, remember, these are 78, 79-year-old individuals, so they're dying of the typical things that older individuals die from: cancers, heart failure, and things that were not likely to move. I think the other point to make is virtually every clinical trial that gets done in cardiology, we tend to enroll lower risk patients. So we've been trying to reconcile how we got from an estimated stroke rate of 2% based on ARTESIA to here. And I think there are two big things. One's hard to measure, and that is just selection bias, right? So are we picking off lower risk patients? Did we pass over patients that had higher stroke risk and not enrolled because, and it's not just stroke risk, let's be fair, bleeding risk is also higher in higher risk patients, right? So, both stroke and bleeding might have been, higher had we taken consecutive patients and enrolled them, which of course almost never happens in clinical trials. The second thing is, we did take care in ARTESIA anyway. I don't know the corresponding numbers for NOAH, but, more than 90% of people, when they crossed over 24 hours of continuous atrial fibrillation, were taken off their study drug and treated with anticoagulants. Because, again, back in the ASSERT paper, there was a 5-fold increase in stroke risk when you proceeded above 24 hours. And, by protocol, our investigators wouldn't allow us to keep people on study drug. And so these patients were systematically treated in about 90% of cases. And we believe, anyway, based on ASSERT, and that this indicated a higher risk zone. So when one considers how we take this to real life, I think you have to take the absolute rates with a grain of salt, although I don't think they're too far off, right? I don't think the stroke risk would have been 2 or 3% per year overall. I think that's probably not true, but I think it's somewhere in between what we saw in the observational trials and what we saw in the clinical trials. The second thing is more of a call to action for our colleagues, is that, this is an ideal circumstance of clinical trials. So we treated most of those patients when they got longer episodes. Nice real world paper out of Australia looking at population-based sample of pacemaker patients suggests in the real world, this happens about 30% of the time at most. And so, again, I think there is room for some space there between what we did in the clinical trial and what's happening today in clinical practice when it's, we're talking about longer lasting episodes.
Yeah, I mean, the one group of patients where I think this effect can be best illustrated is when you compare the high device detected atrial fibrillation episode duration group in ASSERT. it was a clinical trial, but it was done 15 years ago when anticoagulation was just not so much accessible and used. And their stroke rate is around 3% per year. And it's 1.1, 1.2% per year without anticoagulation in NOAH-AFNET 6. I think that suggests, as Jeff says, that this regular monitoring, it's just one ECG every 6 months, but it picks out the people with a high arrhythmia burden, and they are switched to open label anticoagulation. And what remains is a group that is at substantially lower risk of stroke than those with longer episodes. So in that vein, I've only mentioned it in the introduction. When you look at the stroke outcome in East AFNET 4, now these are lower risk population anticoagulation, but it's reduced by 30% numerically with early rhythm control. And we all know that early rhythm control doesn't eliminate atrial fibrillation. These are still patients that have some recurrences of atrial fibrillation, most of them at least, probably rare and short. But you can see a stroke reduction there. So I think
but also, Paulus, just to push back, I mean, it's, you know, you're talking 0.9% down to 0.6, right? So it's a 0.3% reduction. You're dealing with low stroke rate. Again, it's probably a selected population. You know, the East population is not the healthy, you know, it's not the unhealthy general population of patients with atrial fibrillation. It's patients who might have had an ablation. And again, I think although ASSERT's a clinical trial, you know, these in many institutions were, you know, almost consecutive patients getting a particular pacemaker, right? Versus patients you had to convince to take an anticoagulant or not. Again, I think both trials, East and ASSERT, really highlight how you go from a relatively unselected population to a much more highly selected, and the, you know, the rates of everything go down. Let's be honest, the bleeding rates lower in ARTESIA compared to ASSERT, the stroke rates lower, all-cause mortality is 40% lower. So these were healthier patients, no doubt about it.
Well, the rate of stroke and systemic embolism and the rate of cardiovascular death is exactly as we expected in NOAH-AFNET 6. And the stroke rate is half. I think there is, I mean, obviously, well, first thing to say is this is still early days. And I know that Jeff and the ARTESIA group and we are working on sub-analyses, and I think it may be possible to identify subgroup of patients that may have a higher stroke risk. But I do think when you take the things together that we've seen in the last 5 years, there is actually a growing body of evidence to suggest that atrial fibrillation burden or arrhythmia burden, whatever you want to call it, has an effect on outcomes, including stroke. And I think that is, to me, one of the takeaway points of both trials. Stroke rate was low, and we can argue about selection bias, and that definitely played a role, but it was quite a bit lower than expected. And these weren't trials that were designed by people who did their first clinical study. I think there is, it just, yeah.
Yeah, no, I think this we can definitely agree on. I firmly believe also that there is an absolute risk spectrum when one goes from just having frequent PACs at one end to all the way up to permanent atrial fibrillation. And our guidelines don't really have that nuance in them, do they? Like, you know, a patient with a CHA2DS2-VASc score of 0 or 1 who's in permanent atrial fibrillation for years, you know, that patient probably has a higher stroke risk than a person with paroxysmal atrial fibrillation and a CHA2DS2-VASc score of 2. But, you know, we recommend anticoagulation for the latter patient and not the former. It's a little bit of a disconnect. So I think you're right. Moving forward, we do have to incorporate burden. And so, you know, I look at this as kind of like a poker game at a casino, right? You take your chances. And do you want to, you know, are you playing at the big stakes table where the stroke rates are 5 and 6% per year? Or are you playing at the small stakes table where you get to bet 10 euro a hand? But, you know, what we can see is that there is benefit to be had at these lower ends. And I think Paulus is right. We're going to have many papers coming out of both of these trials, which will look at, you know, characteristics of the arrhythmias, CHA2DS2-VASc characteristics, subgroups, and these sorts of things. And I think this will help the community a lot to understand, because I don't think you should treat everybody either. You know, we play up our differences here for the sake of good scientific debate, because that's how we learn. But in reality, I also believe that you're not going to treat everybody with subclinical atrial fibrillation. That being said, I think two things. I think you will see over the coming months that there are a large group of patients where it will make sense to treat right initially, even for short-lasting episodes. And I think, irrespective of that, I think there is clearly an understanding here that we have to do better with monitoring patients when they present with these device-detected atrial fibrillation, because they will progress to longer episodes. About 1 in 3 progress over the course of even moderate term follow-ups. So, and this is progressing to clinical atrial fibrillation detected by the ECG or lasting for more than several days on the pacemaker telemetry. So, I think these patients are going to have a concern for stroke. And then I think what also has to be sorted out at the same time is, what about the relative value of preventing a stroke or causing a bleed? Because I think if you took any patient off the street and said, listen, you're going to have a bad event next year, it's either going to be a disabling stroke or a bleed that you have an 85% chance of leaving the hospital that day with no sequelae, what would you like? I think that's fairly clear cut. Now, you have to factor in the cost and the hassle of taking anticoagulants for the rest of your life. That's true. But I think, there's this added dimension of how do you weight those things, because I don't think they're necessarily equivalent. And I think there's more to learn on that as well, in terms of, weighing strokes against bleeds. But Paulus, maybe you have thoughts on that as well.
To me, the things that we have now are actually, as I said, I think there is still equipoise, but on a higher level. We have and I fully agree with Jeff that a severe stroke is a more serious medical event for most people than a major ISTH bleed. Most of the anticoagulation versus no anticoagulation trials shift the needle also on simple outcomes such as death. This one doesn't, and if anything, it's in the wrong direction. But I don't think that's a real find. I can't say whether that's a real finding, but that's what it is. And I do also think it is worthwhile to recognize that the rate of stroke, in the way these patients were managed with an ECG at every pacemaker visit. I mean, all of these patients, at least in Europe, are seen by a doctor once a year or once every 6 months. And I don't think that every of these visits currently includes ECG, everyone, but maybe it should. And maybe that is already a simple change that makes it easier. And I do think there is an element of adding yet more medications to reduce risk a little bit. And that's why I still think there remains equipoise, even though I fully accept Jeff's arguments that a stroke is more severe than a bleed on average.
You told us these studies will not be repeated, but surely the elephant in the room is the factor 11 inhibitors. Are you already planning, or are you aware of others planning to repeat these studies with factor 11 inhibitors?
Well, that was an interesting question. It's even more interesting in the last few weeks with the Azalea result and the recent termination of the Oceanic program, right? So, of course, there are many molecules. They're similar yet different, and so we'll see. These types of studies typically come up later in the life cycle of drugs after you have a clear win, so to speak, on clinical atrial fibrillation. So I think it would be some time off in the first instance. The second instance is would you convince patients to be enrolled, right? If you have right now these trial results, which suggest some people will be treated out of the gates, like certainly anybody enrolled in ARTESIA that had a history of stroke, you'd probably find very few of those patients being willing to be randomized to placebo if they had 18 hours of atrial fibrillation on their pacemaker or implanted cardiac monitor today. You've got in North America, perhaps more than Europe, you have the ingrowth of the COMPASS trial. It's not as big as we would have thought, but certainly patients with vascular disease are getting the low-dose rivaroxaban plus aspirin, which reduces stroke by 42%. And I think it would be very hard, I think, to replicate these trials with an 11 inhibitor at this point, but I wouldn't hold my breath.
I think it's as Jeff said, I think there is one area that needs to be looked into, and it will be looked into with ongoing trials, and that is how effective are factor 11 inhibitors. But I think the other thing is what Jeff just pointed out. If one wanted to repeat those trials, I think one would have to identify a population in whom the stroke risk is sufficiently high to have a real impact. I don't think either of those trials would have started if we had known at the start that the stroke rate without anticoagulation is close to 1%. And that is, and when you calculate, we actually put this in the trial level meta-analysis, and you have to treat 1,000 people for a year to prevent 3 strokes. Now, these are 3 strokes. One of them is a TIA, but the 2 others are strokes. And of course, you will induce, and that depends on how you count it, between 7 and 16 major bleeds in those 1,000 patient years. Those are the numbers. I think they actually answer your question partially. I don't think these trials will be repeated in the way that they were designed back when we designed them. I do think there is room to improve stroke prevention. Jeff mentioned AF ablation trials. I actually think we need outcome trials in AF ablation, and 1 or 2 are started. I think CABA-HFpEF has just enrolled the 100th patient in patients with HFpEF and AF. But I do think we need more of those. And I do also think that it is probably worthwhile to measure and estimate AF burden more carefully. And that's where the wearables probably have a role, because only a small number of people will ever have an implanted device to monitor rhythm. But almost everyone now has some type of smartwatch. I haven't seen all your wrists, but I suspect that half of us wear something that can measure the heart rhythm continuously. It doesn't do it because we take them off, but I do think that's an opportunity to quantify arrhythmia burden and to see how that links to outcomes in much broader populations than we could envision when NOAH and ARTESIA were started or when ASSERT was reported.
You can kind of conceptualize this for the arrhythmia people on the call here, just like an implantable defibrillator, right? So like an ICD, anticoagulation for atrial fibrillation is highly effective palliative therapy. It prevents the bad thing from happening, but it doesn't alter the natural history of the disease per se. And with better pharmacotherapy for heart failure, we clearly move the needle. And now we're again, as EP docs, thinking for patients with dilated cardiomyopathy, do we really need to do ICD therapy here? Similarly, if you could move the needle substantially on risk factors here, hypertension, weight, heart failure treatment, all these things, and selectively ablate certain patients, you might get rid of the need for anticoagulant in some patients. The caution I would give you is, we're massively going to increase the number of ablations we do over the next 10 and 20 years compared to the last 10 years. But I would argue still you're not going to ablate more than a handful of percentage of patients with atrial fibrillation in the global burden of disease. We're certainly not going to be ablating atrial fibrillation anytime soon in patients we detect with asymptomatic AFib on a Holter, right? We'd be talking about increasing our ablation volumes in Canada, 1 to 200 times if we started, applying that filter. And so I think, for the majority of individuals, if you look at a population level, anticoagulation is still going to be in play for a lot of people, because although we have the abilities to drive the risk factors, the reality is we've seen this with coronary disease, we've seen this with LV dysfunction. The reality is we just aren't that good at moving the needle on a population level by addressing risk factors in a big way. We do our best. Hypertension and stroke prevention is probably the best we've ever done. But we continue to push that. But ablation, again, I think it's going to be first targeted the growth at symptomatic patients with heart failure, where we showed some benefit. Ablation of atrial fibrillation to prevent stroke. I don't think that's in the, I think we'll be happy to prevent stroke in patients we ablate. Will we be performing atrial fibrillation ablations solely for stroke prevention? I'm not sure that's coming in the near future. So I think anticoagulation is still going to be relevant. I think you're going to see over the coming months that we'll do a better job, Paulus and I and our colleagues, to kind of tease out where people who may benefit more, where there are people who may benefit less. And so hopefully that will be enlightening in the coming months.
Yeah, and I think you make a good point, Jeff, and I think the simple operational answer to that is, well, antiarrhythmic drugs are available, they're inexpensive, they are safe when used in the proper way, and they actually were the mainstay of treatment in the early treatment of atrial fibrillation for a stroke prevention trial, with the outcome reducing effect that we have now mentioned 2 or 3 times. So I do think there are ways, not on a population level, but on a level of the average AF patient with recently diagnosed atrial fibrillation. I don't think that is the main topic of today, which is device-detected atrial fibrillation. But I do think that that is probably the simplest way to deliver early rhythm control therapy in the current setting, whilst the ablation centers grow their capacity and train their people and build the EP labs, and at the same time the technology gets simpler and more accessible and more often middle of the road procedure.
So may I have one question to Dr. Healey? I saw in your publication not really a subgroup analysis or interaction analysis with several factors. Many clinicians now would like to know which patient might be a good candidate for anticoagulation. And most likely there are a lot of candidates. Did you observe an interaction or an association of the AF burden, either in terms of longest AF episode or percentage being in AF, with the effect of anticoagulation and on their outcomes? And did you feel that in your population, the CHA2DS2-VASc is really an important factor determining the stroke risk?
Yeah, thanks, Axel. So there are three questions there. They're all really good questions. I need to be careful not to preempt my colleagues who have important papers, but I can tell you they're going to see the light of day in the coming 3 to 4 months. So, we won't have to wait long. I think those are all important, episode duration and characteristics, burden, if you will, CHA2DS2-VASc, and then some refined method, that includes clinical risk factors, arrhythmia risk factors, and maybe even echocardiographic and blood risk factors as well. So those are all coming. I think in terms of public domain, right now we only have what NOAH has presented, which is, there didn't seem to be much happening with burden as best as they could tell. And, but I think you also have to consider, are we talking about a interaction, like a change in the relative risk reduction? Again, in ARTESIA, we have an overall reduction. So does that change? Or rather, are we talking about simply a change in the absolute risk? And I think it's really the latter, right? And again, here Paulus and I can actually get together on this, is that, it's really a matter of, maybe what you show is a consistent relative risk reduction, but that you identify groups who have higher absolute risk from the get-go at the start of the trial. And that would be where I would suggest we think about it, and the data will come out soon. The last comment is both of those things change over time. So you start out with low burden, you may change. And that's when the Van Gelder paper came out. That's its big innovation, was to look at changes over time. And of course, CHA2DS2-VASc changes. Can we do better than CHA2DS2-VASc? Probably. But I think these factors matter, because another thing I like about these trials are, it's quite clear we've gotten to the shortest amount of atrial fibrillation where you might have benefit, right? So if we go any shorter, I would be shocked if we found benefit. I would be shocked if I got funding to do a trial to show benefit, because it would have to have so many people, right? It would be too large to be feasible. I think that's an ideal case for the community, right? Where we found an edge below which we don't have benefit. Now it's our job in the next year to parse out, precisely where those boundaries are. But in general, we know the boundaries somewhere around here. And, whether it's longer episodes or higher CHA2DS2-VASc score, we're going to see in the coming months. But I think that's a really good scenario for the community. I think, although it drags it on for a few months in terms of us finding it out, I think it's really good, because it'll really define, an edge. And I think that's important, not only for our patients in the device clinic, but for this much bigger discussion around what we do about screen-detected atrial fibrillation.
Thank you. Thank you.
And I think, what Jeff said is beautiful. But I think we have already, we've got now 2 really clear data points in populations that we would have considered very high risk if they had ECG documented atrial fibrillation. And we see findings that are still in need of further refinement. Let's put it that way. I think that's a text that Jeff could agree on. And I'm really excited, because I do think we can tease out some of those boundaries. Obviously, the more you split the data, the more you lose power. That's just what it is. But I do think we will be able to provide some more information on what may matter.
Well, thank you so much, Professor Kirchhof, Professor Healey, Professor Bauer. This has been such an exciting discussion. And it was so easy for us because this is obviously what we wished to happen, that you just keep on discussing and we don't even have to ask you a question because all the questions arise and by themselves. And as with all good studies, you provide terrific answers and help for clinical decisions on the one hand, but also open new and more questions so that we may be looking forward to all the further analyses that are probably coming up in the next months. So again, thank you so much for your time and your insightful discussions. And well, wish you all the best. And we're looking forward into this 2024 and all the new studies. And thank you for your time and your work and also doing these studies. Hope to see you soon again. Thanks.
Thank you. And thanks for putting us up. I had good fun discussing this. It was really good. Thank you.